Welcome to Bridging Gaps in Rheumatology, Advancements in Rheumatology Diagnostics with Novel Biomarkers. This panel will bring together leading rheumatologists and diagnostic experts to discuss emerging advancements in rheumatology, with a special focus on NTMCV, a novel biomarker for seronegative rheumatoid arthritis. The session aims to enhance clinical understanding and explore how innovations like NTMCV can bridge diagnostic gaps, enable early detection, and ultimately improve patient outcomes. The session is being organized by Voice of Healthcare and supported by Sibia and Agilus Diagnostics. Join me in welcoming our esteemed panelists for today's discussion. Dr. Bimlesh Dhar Pandey, Director Rheumatology, Fortis Hospital, Noida. Welcome, Dr. Bimlesh. Dr. Varsha Bhatt, Professor and Consultant Rheumatologist, Department of Clinical Immunology and Rheumatology, Bharati Vidyapeeth Medical College and Hospital, Pune. Welcome, Dr. Varsha.
Thank you.
Dr. B.G. Dharmanand, Consultant Rheumatology, Manipal Hospital, Bangalore. Welcome, Dr. Dharmanand. Dr. Shailaja, Sabnis, Senior Consultant, Rheumatology, Nanavati Max Super Speciality Hospital, Mumbai. Welcome, Dr. Shailaja.
Good evening.
Dr. Deepak Sanghavi, Global Vice President and Chief of National Head Operational Global Reference Lab, Agilus Diagnostics, formerly SRL Diagnostics. Welcome, Dr. Deepak.
Thank you.
Dr. Siddhartha Sharma, Head Clinical and Scientific Affairs, Sibia, India. Welcome, sir.
Good evening and thank you.
So I think we have to have the clinical perspective first. So I asked Dr. Bimlesh that what is the current prevalence of rheumatoid arthritis in India or globally, based on your clinical experience?
Hello, but I'm not sure whether I'm audible because I can't hear anyone. So
Yes.
I think I
You are.
try to use any other device. So give me a minute so that I can be back using my mobile device. Nitin, I can't hear what is happening. I was able to hear a bit before. So can you help me out sending the same link? I will try to use the mobile to join. Please. I don't know what happened. What went wrong?
So I think I'll move to the next question. I can go back to Dr. Bimlesh later.
Yes.
So
Yes.
Dr. Varsha, what is early diagnosis of RA? Why is the early diagnosis of RA so critical for patient outcomes?
Yes, so thank you so much to the organizers. Firstly, thanks, Dr. Manisha, for this. So as we know, RA, rheumatoid arthritis, is a chronic and deforming arthritis. So that means whenever the deformities set in, these are irreversible. And our aim as rheumatologists is basically to avoid these very deformities, which are going to lead to a loss of independence in the patient later on, right? And how do we do this? Only by early diagnosis. Why is early diagnosis so critical? Time is indeed joint, right? So as we delay diagnosis and delay the institution of specific treatment that we call as disease modifying therapy, the disease progresses in such a way that erosive arthritis develops and irreversible deformities go on developing. So I think early diagnosis is the most critical point in the care of an RA patient. We operate on two pillars, basically treat to target and hit hard and hit early. So unless we detect these patients early, these patients would have erosive disease and deforming arthritis. They would lose their disease. This is what we're trying to avoid.
Right. So early diagnosis is really important to
Very
prevent
important.
erosive arthritis. Right. So Dr. Bimlesh, have you rejoined? Can you hear me, sir?
Yeah, I can hear you. Can you hear me?
All right. Yes, definitely.
Thank you.
So I think, sir, I need to know the burden of rheumatoid arthritis because I think it's so prevalent in India and globally. So based on your experience, can you tell me what is the prevalence like?
Thank you. It's a very relevant question. For our population, we should know how many people are affected by rheumatoid arthritis or any inflammatory musculoskeletal disease. And since it being a chronic disease, we carry on this disease and its burden for lifelong. So there are a good few works that have been done in India, and one of the work that one needs to quote is the work done by Dr. Arvind Chopra, the Big One model in uh, Pune and the areas around Pune. The other work was done by the team at Rheumatology at All India Institute of Medical Science, first Dr. A.N. Malviya, followed by Ashok Kumar, and then later on by Dr. Handa. And I was one of the members doing the Big One model to understand the disease, inflammatory musculoskeletal disease prevalence in and around Ballabgarh, a locality which was under All India Institute of Medical Science. A few work were also done in the eastern part of India. But never says if you combine most of these works done at SGPGI, AIMS, the Big One model of Pune, you would get a rough estimate of prevalence between 0.28 to 0.75. Now, if I try to extrapolate all these, I would be also biased to say that certain areas do have a larger burden and some areas do not represent as well. And one of the area which I think has not been well studied is the Uttarakhand, because if you see the regional diversity of our country is very complex. So some of these areas are remote areas and they have very high disease prevalence of all the musculoskeletal disease, just not rheumatoid And to summarize it, I would say 0.75 would be the percentage would be the rough prevalence of rheumatoid arthritis. It is the commonest inflammatory disease in India.
Right, sir. Sir, thanks for giving us a snapshot of its prevalence because if we know what the burden is, we can definitely hit it hard. Dr. B.G. Dharmanand, how has the diagnostic landscape for rheumatoid arthritis evolved over the last decade?
Thank you. The diagnostic landscape has changed in the last 2 decades, I would say. I've been practicing since 1997, where getting a rheumatoid factor itself was a difficult task, and we most of the rheumatoid factor test availability was only RF latex, and subsequently, with the advances in lab technology, spectrometry and calorimetry came up, and so rheumatoid factor test became much more robust and believable. The last 10 to 15 years, the availability of anti-CCB has has made a huge changes in the ability to diagnose rheumatoid early, particularly if they are rheumatoid factor negative. And also, so we have to know that rheumatoid factor can be positive in so many rheumatological diseases, including lupus, dermatomyositis, scleroderma, etc. So even presence of rheumatoid arthritis, rheumatoid factor alone will not help us to confirm the diagnosis of rheumatoid arthritis. So anti-CCP was a welcome addition to a rheumatoid factor, and if both are positive, then we were sure that the patient had rheumatoid arthritis and not any other connective tissue disease. And so, and the availability of anti-CCP and also the advances in the technology, the latest versions, and with the increased usage, the cost has come down. So it has become now it is easily available and routinely used. So that has enhanced our ability to pick up rheumatoid arthritis as early as possible.
Right, sir. So I think the rheumatoid factor and addition of NTCCP and now the NTMCV is another, welcoming thing, which I think is fitting into the diagnosis. And that is what we have to explore here. So Dr. Shailaja, how do you see the limitation of current markers like RF and NTCCP in routine practice?
What Dr. Dharmanand has told is absolutely right. When we started practice in rheumatology, we only used to do a CBC-ESR, a C-reactive protein, and a RA factor. Anti-CCP came as a research molecule around 15-18 years ago, but for most patients to get it in hand was around 10 to 12 years ago. It was pretty expensive. When we started writing anti-CCP, people or the general practitioners would ask us, really, is it required? But what we realized is there were a 30% patients who were RA negative, but we thought definitely these were inflammatory arthritis. Now the ULR criteria have changed, but at that time RA factor positivity was a major criteria. So once anti-CCP was coming into the market, easily available to patients, we could actually pick up our early RA patients. We could tell these patients that you may be RA negative, doesn't mean that you are not rheumatoid arthritis. You are definitely rheumatoid arthritis. You are RA negative. That means that you are RA negative, but there is another test which is anti-CCP positive. But even now, I feel there are a group of around 10 to 15% patients who may be RA negative, anti-CCP negative, but we need furthermore tests which would tell us that is this a patient of inflammatory arthritis and is it RA or it is something else, because you could have lupus patients, Sjogren's patients who are rheumatoid arthritis. So with MCV, we have seen that more and more specific rheumatoid arthritis patients have been picked up. Another thing in clinical practice, what I've noticed is all these newer markers, if you put all three together, you would pick up more number. I mean, even the area under the curve tells us. So if patients are affording, I think you should give them a panel of group test. Like you ask for a arthritis panel, you do a RA anti-CCP as well as the AMV test, which will definitely pick up our rheumatoid arthritis patient early. As Varsha has said, picking up early, treating them early is very important. Whichever state or village or city you are practicing in, you need to tell these patients that do not believe others. Even if you are RA negative, you have these markers which are positive. More extra smart patients can go on to Google and check what we are talking about, and then they would follow our combination DMARD therapy or other therapies, which as a consultant rheumatologist we tell them to do so.
Right. I think you have summarized well that we have to convince the patients as well as the clinicians that how these tests are important to diagnose the seronegative rheumatoid arthritis. And since we have NTMCV available with us, I would like to ask Dr. Deepak Sanghavi that what is it and how does it differ from RF and NTCC?
So thanks to the organizers and good evening to everybody. We had a very good know-how about the whole test from the clinician side. So I'll be introducing this marker from the laboratory perspective. So first thing is MCV. The full form is mutated citrullinated vimentin antibody test. So also called as anti-MCV test. So what it is, simple blood test. We do it on a fully automated machine and we give you report on the same day. So from the laboratory perspective, it's a very simple test to give a report. But I will discuss the importance of this test. So basically, it has a very important role in the pathogenesis of the rheumatoid arthritis. It is released from the macrophages of the which are present around the synovial tissue when there is an inflammation. So from these macrophages, this marker comes out, and that is what we are actually detecting. If I will discuss later on also, but it's just to tell you that it comes as early as 24 months than the actual clinical symptoms which are seen in the rheumatoid arthritis. So it's a early marker because it is detectable at least 24 months before the disease. Considering sensitivity, specificity, so we all use rheumatoid factor as a common screening test. The sensitivity of rheumatoid factor is around 60% and specificity is around 80%. While we go for, that is why there was a need for another marker which came in, which we are commonly using, as we have discussed, we have understood from the clinician side that CCP is a common marker when RA test is negative, or as a supplementary marker CCP is used. CCP is anti-citrullinated protein antibodies. In anti-citrullinated protein peptide antibodies, the sensitivity is around 62 percentage, while specificity is very good, 94 percentage. So they become complementary to each other. But we have also understood that there are seronegative RA cases and as well as seropositive RA cases where the values could be in the borderline zone for RF and CCP, and there's more confirmation needed. So as we have seen that 20 to 30% cases are seronegative cases. So there is a need of a marker to detect those cases, and hence MCV has become an important marker in this current scenario, and we have this marker available which closes the gap for diagnosis. We also have American College of Rheumatology and European League of Against Rheumatism, which we will be discussing also in detail later on. These guidelines also talk about serological markers and important markers for helping in diagnosis. So what is this MCV marker important? So MCV is basically, as you have understood, it's a neutral protein Y-maintain antibody test. It helps for early diagnosis because 24 months early detection, very sensitive, specific as compared to RA-CCP. Here, the studies have been done which says that the correlation with the disease as well as the different stages of rheumatoid arthritis, it's a very complex course of disease where you have a preclinical phase, then there is the early symptom phase, and there is an established RA phase. And in established rheumatoid arthritis also you get active phase and remission phase. All these phases, the antibody levels fluctuate. And in that, MCV has been seen to be a very good correlating factor for every stage. So early phase also it is with very good correlation. During the active phase also it has very good correlation. During the remission phase also it has very good correlation. Hence, it is a very good supplementary marker, in fact, an additional marker to both RA and CCP. That is why we have also launched a test which is called extended RA panel, which is also we will discuss in the second part of the presentation. And it is now becoming a prescription practice from all the clinicians who are now knowing about this marker. And we have found that in our own in-house data, which we have done it, like out of 4,500 patients of RA, we get normally 13% positivity. Out of all the CCP, around 6,000 workload that we have, we get 26% positivity because we know it is done as a complementary or a backup test for RA. But MCV, which has recently been launched, we have done at least 150 cases and our positivity rate has been 40%. So this has been prescribed by the clinicians who were suspecting RA, but they were not having a serological marker positive, like RA and CCP may be negative or maybe borderline, and for confirmation it was sent. And we found that 40% cases were positive, which helped the clinicians to diagnose the rheumatoid arthritis case. So we will discuss the other part of the presentation in the second part with Dr. Siddharth Sharma. I will request Manisha to take this ahead.
I think you have given a very practical, insight that 40% rheumatoid arthritis patient can be detected with the help of extended RA panel, which you have, launched. Congratulations to you for that. And Dr. Siddharth, how do you see NTMCV becoming a game changer in diagnostic algorithm for us?
Yeah, so thank you, Dr. Manisha. Taking on from what Dr. Deepak has stated, and it's actually very heartening to know that if we are getting a positivity of 40% with anti-MCV, that in itself speaks volumes on the utility of this marker, more so when it comes down to a seronegative RA cases. So this itself states that it's a paradigm shift in the diagnostic spectrum of RA, and definitely it's a game changer in itself. And one point I would like to emphasize here, although Dr. Deepak has already spoken on what MCV is, but the point here to understand is why MCV is giving this kind of positivity which CCP is not able to offer. So what is that major difference which exists between CCP and MCV? So that difference lies in the type of antigen which is being used for testing. So basically, definitely CCP is kind of considered the gold standard. That too, CCP generation 2 is considered as a gold standard. But the point is the antigen being used in the CCP testing is not a native antigen. It's a synthetic antigen. It's a filaggrin-based antigen. And as Dr. Deepak already stated, Vimentin is a native antigen to the joint. So this is itself very important to understand, more so for the rheumatologists, that when they are dealing with antibody positivity with CCP, they are sort of getting the cross-reactive antibody positivity, whereas with MCV positivity, they are actually seeing the antibodies which are involved in the etiopathogenesis of rheumatoid arthritis. So this difference in the antigen itself is a huge kind of a value proposition which offers a better diagnostic sensitivity and specificity for RA diagnosis. And also additionally, MCV, because it's not just vimentin, it is not just citrulinated vimentin, it's a mutated citrulinated vimentin. So this mutation itself offers 40 more epitopes for antibody detection compared to a citrulinated vimentin. So considering these two factors, that not only it being a native antigen, but being an additional mutated citrulinated antigen, the detection rate for antibodies which are involved in the etiopathogenesis of rheumatoid arthritis is very high. Thus, it offers a better sensitivity and specificity. And at the end, with what Dr. Deepak has stated, it boils down to being a ultimate game changer in the diagnostic spectrum of rheumatoid arthritis. So yes, that's what I would like to say. Thank you.
And to add to Dr.
Right.
Siddharth Sharma, like from the laboratory side, we know that the guidelines of ACR talks about a good score, which is major score is also given by the serological apart from the clinical side, and hence we need to do the blood test. So it's an evidence-based thing that medicine that we need a positive test or even a seronegative. Also, we want something as a positive for a good treatment purposes, and hence this marker is going to become an important game changer for us. And hence we have created a profile called as extended rheumatoid arthritis profile, as Dr. Shailaja suggested that there should be a profile. So we have already created one where we have RA, we have CCP antibodies, we have MCV antibodies, and we also have ANA along with that, so that we can pick up other cases which could have been not so in rheumatoid arthritis but some other autoimmune phenomenon. So these 4 tests will help to not lose a case of rheumatoid arthritis for a delayed diagnosis. Over to Manisha.
Right. I think this is a very important point, that it is just hitting on the etiology part of it, and it's an inherent antigen, which we are targeting with the help of antibodies. And specifically, as Dr. Siddharth said, that 40 newer epitopes can be detected with the help of anti-mutated citrulinated vimentin. So my next question goes to Dr. Varsha. What percentage of RA patients do you typically see as seronegative?
Okay, so thank you so much for that, Dr. Manisha. This is important. So in our practice, normally we see that around 30 to 35% of patients presenting with inflammatory arthritis are seronegative for both rheumatoid factor and anti-CCP. Now, as the other speakers have brought out, like Dharmanand sir and Shailaja, Dr. Shailaja said, labeling someone as a seronegative RA can be a diagnostic dilemma, actually a challenge, because now the patient is presented so much like a symmetrical polyarthritis, inflammatory. You're almost sure that the patient has rheumatoid arthritis. There may be nothing systemic at all in him or her. But the markers are coming negative. The inflammatory markers are coming high. The ESR and CRP are high. But both the RF and the anti-CCP are negative. So there are around 30 to 35% of patients who do fit that bill. That is where we need the additional markers that you are now bringing out, like anti-MCV. I think that really will change the paradigm of seronegative RA. Having said that, as I said, it's a diagnostic dilemma. So what all can be there apart from just rheumatoid arthritis in this kind of a patient? So we may miss psoriatic arthritis, for instance, because polyarticular psoriatic arthritis is a very common mimic of RA. Even inflammatory osteoarthritis, especially in elderly onset rheumatoid arthritis patients, if they are seronegative, and which most of them are, a lot more of elderly onset rheumatoid arthritis, almost 50% can be seronegative. But they could have inflammatory OA as well. Also, connective tissue disorders, like I think Shailaja brought out that, lupus and systemic sclerosis, all of them can present with inflammatory polyarthritis. They may not initially have all these symptoms as in a multi-system disorder as they present. They may just come with an inflammatory arthritis. So we need to categorize SNRA very well, I feel, because otherwise they can throw up surprises in a couple of years down the line when they evolve into something else. That is where I feel anti-MCV has a huge role to play, because it is more specific or more sensitive than the current citrullinated polypeptide groups. And I feel they can pick up more of rheumatoid arthritis. So it'll become so much easier for us to label a patient as rheumatoid arthritis in currently seronegative status. And having said that, seronegative arthritis also, seronegative RA also has different genetics, different genetics, different cellular and immune drivers, different prognosis. So I'm sure Sir would also highlight it a lot
Yeah.
more.
Yeah. So, Dr. Dharmanand, can you just enlighten us that what percentage of rheumatoid arthritis patients do you typically see as seronegative? We can't hear you, sir.
Yeah, as others have alluded to, and as the literature points out, around 20 to 30% of our arrays will have anti-CCP and rheumatoid factor both being negative. So they are true seronegative at this moment. As Varsha was alluding to, seronegative RA is a working diagnosis. Many a times they evolve into something else if you follow them long enough. Some of them myositis, some of them psoriatic arthritis, etc. So if we pick up another 10%, 15% more with an anti-MCV antibody, that would probably help us to categorize them as rheumatoid arthritis. And immunologically also, seropositive rheumatoid arthritis have a different therapeutic response vis-a-vis seronegative rheumatoid arthritis. Sometimes it can be very mild, sometimes it can be very difficult to treat. So knowing whether the patient has got an antibody is an important tool. And double positive, triple positive, and four quadruple positive RAs have a poor prognosis. So more antibodies people have, more poor prognosis they have. So if as somebody, Dr. Deepak was alluding to, an extended RA panel in an early rheumatoid arthritis comes positive for all the four, and that would probably put this patient into a more aggressive phenotype, and probably we need to be very aggressive with the management plan.
Right. So that is also important point, that it's got the role in prognosis as well, that if more markers are positive, it has got poorer prognosis. Dr. Shailaja, how do you currently manage seronegative RA cases, and what are the biggest diagnostic challenges?
Yeah. So again, back to the same problem. What happens is basically what we start with seronegative, when we have a RA negative, anti-CCP negative, most patients feel they do not have rheumatoid arthritis. They keep on going from one pillar to other. If happily and better treatment goals were to be achieved, and if they reach a rheumatologist within the first 6 weeks to 3 months, I think many of these patients could go into near total remission or at least low disease activity. So it is very important that we need to bridge this gap by educating even general practitioners with the extended panel available, so that they would also be doing it before sending it to us, or they send it to us earlier. Many times earlier, I mean not now, but we would always been told that seronegative arthritis hai, daro mat, kuch nahi hoga. But that is not the true fact. Many of our seronegative arthritis could be aggressive psoriatic arthritis, aggressive rheumatoid arthritis. If we are following up in our general OPDs, we see that many of these patients after 10 years are a total different picture than what they were. Or they could be having, if they turn out to be MCV positive with high titers, like the cutoff value, what they have suggested is 20 international units. But if you find that initially they are RA negative, but they turn out to be MCV positive with high titers, mind you that you should look out for interstitial lung disease in these patients, look for the cardiovascular risk in these patients. Earlier we used to think that seronegative arthritis never have an aggressive role to play, which is not the truth. So whether to start combination DMARDs, whether to go ahead with use of newer drugs, if the MCV picks up, definitely, but don't feel that you should not treat these seronegative arthritis with combination DMARDs. So look at the inflammatory markers, look at the disease activity score. So any DAS score about 2.8 with even one or two markers positive, definitely a aggressive treatment should be done so that the DAS score comes down, make the disease activity to the lowest possible activity, if possible into remission, educate the patient that they need proper follow-ups and proper treatment therapies.
Right. So my next question is to Dr. Bimlesh, that if a newer marker like NTMCV can detect disease in such patients, how valuable would that clinically? Sir, can you hear me? I can't hear you, sir. Dr. Bimlesh, please unmute yourself. Yes.
Sorry. So let me go back to what we were talking, the prevalence. So if you do the prevalence study, and one of the prevalence studies said that the positivity was around 100% when they were sure about, when they had NTCCP positive. So they were trying to look into the seropositive and seronegative. So they were able to figure it out, seropositive as a true cases, and they had some doubt about seronegative. So one, it helps as a clinician to clinch your diagnosis and treat them appropriately. Now, when you have an early disease, it is the best opportunity to make or clinch the diagnosis and treat it effectively as well. So if I have the anti-vimentin MCV available, where I may not be able to, make a diagnosis just based on rheumatoid factor, because that's not positive in high titers, it's just positive, then this is going to aid me. But if I have a very high titers rheumatoid factor or CCP, I need not move forward to MCV. But if I get tomorrow a class of, study protocol where I get anti-MCV and rheumatoid factor as my first line investigation for suspected rheumatoid, it would be always uh, an aid where I will be able to make a bit more amendments to the seropositivity in the initial phase. Let me go back again. If you see the classical studies, most of the rheumatoid arthritis, up to 53% were seronegative to begin with, and they added up those antibodies later on. This was a very long back study that was done. So if I have a specific or more sensitive and a more specific marker for rheumatoid, I would be able to use this marker to aid the diagnosis and treat. As a clinician, if I see inflammatory arthritis, I would be using the DMARD. But then labeling also helps you to think about what are the outcomes. So antibodies do give you an idea. For example, strongly positive anti-CCP always gives an idea it would be an erosive disease. Strongly positive rheumatoid factor gives you more inflammatory, signs and symptoms. So that actually gives you idea. Triple marker or double marker means you are highly likelihood of getting complication, whether it is extraarticular, into the lungs, vasculitis, etc. So everything in totality aids you, and if you make an early diagnosis, it's the best thing that you can do to your patient with a very good effective outcome.
Right, sir. And Dr. Siddhartha, I think several studies suggest that NT-MCV has, higher sensitivity and specificity in early RA and in seronegative patients. From your review of literature, how strong is the clinical evidence supporting its use?
Yes. So, as we know, MCV actually was discovered in the year 2008, and it's been now 15 plus years since it's been there in the diagnostic spectrum for rheumatoid arthritis. And as of date, there are more than 100 plus peer reviewed scientific publications around it. Around 15 plus clinical trials have been done considering its diagnostic sensitivity and its efficacy, along with its role in therapeutic monitoring of patients, and around 10 plus publications which highlight the value of this marker in early diagnosis. So when we talk of from a publication or from a study point of view, how all this evolved is when it was the rheumatoid factor which actually came into being. And then after rheumatoid factor, there were a lot of scientific studies, a lot of publications which came forth, which started highlighting the pathophysiology of citrulline vimentin in the pathogenesis of rheumatoid arthritis, and also additionally the mutated form of citrulline vimentin in providing a kind of an optimal epitope exposure in enhancing the immune recognition for antibodies, thus enhancing the sensitivity and specificity of this marker. So it started from going beyond rheumatoid factor, looking at native joint proteins. In that is how the term ACPA also evolved, and from ACPA, how are the other native joint proteins which can have a role in etiopathogenesis. So vimentin is one of the proteins, but yes, a lot of study has been done on vimentin and citrullinated vimentin. So this is how the studies have stated the evolution of not only vimentin but also of MCV per se. And now there are numerous studies which also state that it has a very predominant role in early detection of rheumatoid arthritis by highlighting its sensitivity and specificity, more so in the pre-RA cases, where it is a better predictor of disease onset to the extent that it is detectable even 24 months before the actual disease sets in. So yes, it helps in early detection, and also as we have already discussed a lot for seronegative rheumatoid arthritis. So definitely considering that it being a native joint protein, many studies are still being done. But what is important to understand is the population which is being studied, because as we all know, and this holds true for in autoimmunity space, there is difference in the population, the population sample which has been taken for studies. So definitely these studies are more from the Western aspect. But yes, now with the availability of MCV in India per se, I believe that studies can be done in India, which further will highlight, like Dr. Deepak's lab is already reporting a 40% since positivity in CCP negative cases. So yes, and also more studies on the early diagnosis of RA patients, more so with the high risk individuals who already have a first degree relative with RA positivity, RA disease. So yes, those studies also can be now be done in India. But definitely at the end, the message is that it's the marker is a very validated, clinically relevant, and a very pathophysiologically aligned biomarker for rheumatoid arthritis. This is what the studies at the end have come as a broad consensus. So definitely this is where the scientific literature and the publications are pointing towards to. Thank you.
I think it's really helpful that if it can diagnose RA patients, 24 months before the symptoms appear, I think it's really important. So, Dr. Varsha, do you see potential of NTMCV in treatment monitoring and prognosis as well? And how can labs contribute to that?
Yeah, so thanks a lot for this question. I think that's really relevant to today's discussion. As all the speakers have pointed out, anti-MCV is coming out to be a game changer in seronegative rheumatoid arthritis, where the traditional markers are coming negative. And it is shown to have a higher sensitivity in these early seronegative rheumatoid arthritis cases to pick it up more early. So as far as treatment, monitoring, and prognostication of the disease goes, can it really help us? So I was reviewing some of the literature, and the studies which have been recently done do point to it contributing as a prognostic marker. I mean, if a patient is, for example, even if he's seronegative for rheumatoid factor and he has anti-MCV positivity in an early stage, they may go on to have a more aggressive disease course, is what was given in some literature that I saw. There was a study looking at anti-CCP positive and anti-MCV positive patients, and they seem to have a worse clinical prognosis than anti-CCP positive patients alone. So maybe we need more data on this, especially in India, in Indian scenario. But it is looking to be a good marker for an aggressive or a more erosive rheumatoid arthritis. Also, so you can predict that more earlier in the disease as compared to the other markers is what another study was looking at. Like how early can you predict that this disease is going to be more aggressive, both articular space and also in extra-articular manifestations. So maybe it has a role to play there as well. It has a direct correlation with DAS28 is what was another study saying, that it has a good correlation with a robust correlation with the parameters of disease activity, the inflammatory markers, the tender and swollen joint count. So everything that makes up DAS28, more so than anti-CCP and RF. So I think that is where we need to look at anti-MCV as being a potential game changer. For treatment or therapeutic monitoring, the jury is still out, though like traditionally it is believed the seronegative patients do not respond or may not respond that well to rituximab, for instance, or anti-B cell therapies. Would anti-MCV, change that as well? It remains to be seen, although early literature does say that anti-MCV positive patients may do better on certain therapies like anti-TNFs or even B-cell depleting therapies. So we need more data, as I said, in the Indian context to whether it can act as a therapeutic prognostic marker, or rather, prediction of therapeutics. But definitely, as far as disease progression goes, anti-MCV is coming out to be a marker that may predict a more aggressive disease course and more erosive course as well.
And Dr. Bimlesh, if NTMCV becomes widely available, how will it change the RA diagnosis landscape in another, say, 5 years?
So going by the specificity over and above rheumatoid factor, it makes sense to have this to be quite sure that we are labeling the disease correctly. And we know that rheumatoid factor can be positive in multiple conditions, including rheumatoid and other diseases, whether it's lupus or Sjogren. So, once you make a correct diagnosis, you are much, thoughtful of your choices of your treatment modalities. You are also expected to think what are the complications associated with a disease. If you have made a correct diagnosis, uh, everything said and done. Rheumatology is also known to have a very important aspect called as a time frame, in which you may make a label or label a disease A, and over a period of time you may go on to say no, it is behaving something like others. But if it is widely available, it will be widely taken up as well. You are more sure that CCP, now MCV, is more specific to rheumatoid. And probably I would like to also know whether past history of tuberculosis, sometimes can have anti-CCP positivity, but does it also have something to do with anti-MCV positivity? Treatment choices, as Dr. Varsha said, seropositive, we would like to tend to use a B cell depletion, more than anti-TNF in day-to-day practice. So eventually, the choices of drugs, the outcome are also dependent upon the type of disease that you deal. And the typical phenotype of rheumatoid may have a subtype where you have an anti-CCP positive or anti-MCV positive, but rheumatoid factor negative, you have double positive or triple positive, or you have a true seronegative. And they may behave differently over a period of time. That is also expected for the different, sub, class in, say, so-called rheumatoid arthritis. But it is always good to know that if you have another stronger or specific biomarker, which can aid your diagnosis, also aids your early treatment protocol.
Rightly said, sir. We can label a patient as rheumatoid arthritis patient. That is really important as far as the treatment protocols are concerned. So, Dr. Shailaja, what is your advice to clinicians and lab professionals for integrating NT-MCV into routine practice?
Yeah, so like as early as I said, one is the cost If we have patients who can take the complete panel, I feel we'll pick up more number of patients. One, we would pick them up much earlier. Availability of these tests to more number of counters. I mean, not just multi-speciality hospitals, but at multiple places where the labs are available, and explanation to even general practitioners, not just consultant rheumatologists, that these tests are available. So if at least if a patient is affording, definitely do it. And if the patient you feel has inflammatory arthritis, even to the young rheumatologist, I would say that please do a complete panel, or at least in patients who are RA ACCP negative, and if you feel they have inflammatory arthritis, definitely ask them to go ahead with the MCV test and the ANA test if not done earlier. Because I feel many of the clinicians yet forget to see these patients in a different perspective. I mean, seronegative arthritis, what happens is many times after 10 years you realized, oh God, you should have seen these things. They had come earlier to these rheumatologists, and they have not picked up lupus, not picked up Sjogren's, or even seronegative arthritis could be in males a presentation of spondyloarthropathy. So if you have definitely ruled out rheumatoid, think of other types of seronegative arthritis. So you cannot give the same DMARDs or the same biologicals. So whether they are going to respond to rituximab, whether they are going to respond to TNF alpha or to the new JAK inhibitors, we need to have a detailed study of these. And I feel if the cost definitely decreases for the panel testing, most of us would directly ask for the panel testing. That is one. So treating and hitting them early in disease would be first. Diagnosis would be much easier for all our patients, and explaining to a group of nasty patients who feel that I'm RA negative, ACCP negative, so why are you starting me on DMARDs, would also be answerable to many of these patients, because you would pick up around 10 to 15% patients who would yet be RA and we have not diagnosed them. Thank you.
Right. So I think that 10 to 15%, ma'am, is very important to label them as, RA positive patients if specifically other factors
And
are negative.
there are other studies also which have showed that if your MCP levels, anti-MCP levels are very high, remember to look for cardiovascular. So extra-articular manifestations, like Dr. Dharmanand said, that if you are RA, ACCP and MCV positive in high titers, remember to note that these patients could definitely have bad extra-articular manifestations. So monitoring these patients for ILD, myositis, as well as cardiovascular risk. There are studies from the Western world which have proved that high MCV titers definitely have risk of ILD progression in many of these patients.
So I think the prognosis and catching the extra articular manifestations also is there. So Dr. Dharmanand, any point you want to add, your perspective on this, that how clinicians and lab professionals can integrate NTMCV into the practice?
Yeah, thank you. I noted one good observation from Dr. Deepak's presentation. He said when rheumatoid factor, they analyzed only 10 to 15% were positive. CCP was analyzed some 20-30% positive. And anti-MCV, 40% of the patients who were referred were positive. See, we need to understand the sensitivity and specificity of the test based on the population or based on the doctors who request it. Same test, a rheumatoid factor test requested from a general practitioner, only 10% of them may have rheumatoid arthritis, and only 10% of them can come positive. It comes from a physician's, an orthopedic surgeon's clinic, maybe 30-40% might be positive. But they come from a rheumatology clinic, maybe 80% of them will be positive. So your higher percentage of positivity for MCV, probably they were highly suspected to have RA and they were negative, and that this test was ever asked for. That's why we have a higher percentage of people being positive. So we read about sensitivity, specificity, but we don't really understand the context. If same like a ANA test asked from a general medical ward when they are evaluating fever, sick patients, the chance that the positive ANA patients will turn out to have lupus is very small. But in a rheumatology outpatient or an inpatient clinic, if a ANA is requested, almost 80-90% chance that they will turn out to be lupus, because the index of suspicion is very high. So these are the few points we need to understand when we interpret this test. And as I think Shailaja was telling, the cost of the test also matters when we integrate this into practice. If it is reasonably affordable, if it is in the range of current CCP test, and it can be used in the early stages, depending upon the cost. After RFCCP is negative and we can still do, or as a part of an early rheumatoid arthritis profile, we could integrate. So these are the few observations I have. And knowing more about the presence of pathological antibodies, I'm sure because of the nature of the antibody, they are very likely to be pathogenic antibodies, and they can be labeled as seropositive RA. Like once the seronegative RA, if they turn out to be anti-MCV positive, then it will become seropositive RA and they will behave like seropositive RA. There are few things, seropositive RA patients, methotrexate, anti-TNF, many of the abatacept, they respond better for seropositive patients than seronegative patients. Untreated seropositive patients don't do that well. So these are the few nuances I think we should understand. I think that's it from me.
Yeah, but
Right, sir.
one case I can add, Dr. Dharmanand. I found a case where one area where the patient was on treatment and on the remission stage, but to just check for remission, that patient had done a CCP in two different labs. One lab gave a borderline positive result, and one lab gave a negative. So patient wanted to know whether really it is remission or not. So in that case, we did an MCV, it was negative. So we could assure the clinician and the patient that you are in remission stage, that borderline value of CCP may be due to other reasons. So it also helps in the confirmation of remission stage when you have such scenarios of different values in different labs.
Right. So it gives you the answer, I believe, not only labeling the patient as rheumatoid arthritis, but also for catching up with the patient. Very well
Dr.
said.
Manisha, can I just add here just
Yeah.
one input? Now that when we are talking of therapeutics for rheumatoid arthritis, the therapeutic spectrum is moving beyond the biologicals in rheumatoid arthritis, and now we are entering the era of T cell engager therapy and CAR T cell therapy for rheumatoid arthritis. So there is a good article published in the NEJM which looked at the efficacy of the T cell engager and the CAR T cell therapy for autoimmune patients and rheumatoid subset, which was considered one patient. So, yes, they looked at both the CCP2 and the MCV levels in that particular patient, and both MCV particularly correlated very well with the response the patient had to the T cell engager and the CAR T cell therapy. So, yes, going forward with the newer therapeutic modalities now, definitely it can become a diagnostic companion to monitor in such particular modalities. So yes, definitely. I mean, it's something futuristic now. That is what
Yeah.
I would say.
That
Thank
was
you.
an interesting study. The CAR T cells were targeted, like citrullinated
I
tissues
mean,
wherever
yeah,
citrullinated proteins are expressed. So that were predominantly in the synovium. So they could get a good control over the synovitis in these patients. It's a very preliminary data, interesting data. They didn't
yes,
target T cells like what they targeted in SLE. They
exactly.
targeted the tissues which expressed citrullation. That was the target for the CAR T to go and attack.
Yes,
I think that is what is evolving, and we are learning, day by day. And I think research is going on in extensive manner, and the futuristic, I think, diagnostics as well as therapeutics are really exciting. So my last question would be to Dr. Shalja, that how important is awareness among the general physicians and patients for early referral and testing with these newer markers?
Awareness is extremely important. I mean, it's not just the rheumatologist. I feel awareness should be done to multiple groups of people at different levels. I mean, the things what you talk to a rheumatologist should be very different. I mean, I'm talking with about the lab professionals who come to tell us about the test versus the general practitioners. I would still say that do not give a RA extended panel to the general practitioners. It would be done for different reasons. I mean, but definitely orthopedics or physicians, you could tell them that the extended panels are available and in these labs. If you feel that there is inflammatory arthritis, you should be knowing it. But information in public also should be given. I mean, most of our educated patients definitely Google up about all these tests. We have Western world data, but like Dr. Deepak has projected that he's seeing now many Indian doctors sending him patients. If we could put it on certain YouTube panels or some Facebook data, if privacy norms allow him, we would at least tell our patients that see, this is a new test and it will pick up more number of patients, and it could pick you up as a rheumatoid arthritis patient as early as around within the first 6 weeks after symptoms. There are mothers who keep on complaining and asking me, will my daughter get some severe aggressive disease? So in fact, even before marriage or planning of a pregnancy, if they have a genetic history, we could ask for a an MCV test to tell them that no, definitely your tests are negative, and I don't think so she has arthritis. So, along with the inflammatory markers, if you definitely want these patients to know that definitely there is no problem with you, I think that would be better. But education at multiple levels, like it's not just to the rheumatologist. I think most of us read up a lot, and like Dr. Dharmanand sir told us that from which place you are getting is very important. I mean, sensitivity and specificity when you're checking up, I feel you should do as a group. I mean, not just rheumatologists. You definitely get very high titles. You should do it from the general practitioners in India at multiple levels, at rural levels, at the city practice also, and you would really know the values of the sensitivity and specificity. So education to each and every doctor is very important. It's not that you should not give, but these extended panels I think should be reserved to patients, one who really you suspect they have a very bad erosive disease, or number two is when you're expecting that these are definitely RA-ACCP negative and still you feel that they're seronegative inflammatory arthritis, you could ask for a MCV test.
Right. And Dr. Varsha, please tell us that how aware are patients and general practitioners in using these extended panels?
Yeah, so I think all the panelists have brought it out beautifully, Dr. Shailaja and Dharmanand sir also, that we do need to create awareness amongst general practitioners, physicians, orthopedic surgeons, and even patients and lab personnel. Mainly, we need help from our lab about these newer biomarkers like NTMCV to pick up the seronegative rheumatoid arthritis patients. I think we've discussed that extensively. But having said that, I think a lot of responsibility lies on us. Like Sir was pointing out, that a pre-test probability in diagnosing, for example, rheumatoid arthritis or lupus is very, very important. And if you give the extended arthritis panel in the hands of, maybe GPs, there may be, not they may not use it correctly. That also may be one of the things I'd like to bring out. Lab personnel, most definitely, we need to create awareness amongst them, because an extended arthritis panel can point to a more aggressive disease, as we've all talked about. And when put in the right hands, it is a beautiful tool to predict which patients are going to do poorly, which patients are going to respond to certain therapeutics, and which patients, may land up in co-morbs such as cardiovascular disorders at the end of the day. Creating awareness amongst physicians is very, very important, because they are an important referral point for us. And as I pointed out very, very early, that early detection of RA is so, so important. And putting this tool in the right hands is what I'm, just campaigning for. And it will help us manage our patients better. and help us point out to aggressive disease better. But putting it in the right hands would definitely help do it better. That's what I'd like to say. Thank you.
Right. So, on that note, I thank you all for joining us today and creating a ripple around this newer biomarker that is NTMCV. Thank you so much.
Thank you so
Thank
much.
you.
Thank you all.
Thank you.
Thank
Thank
you
you.
all. Thank you.
Thank you, everybody.
Pleasure.
Bye.
Bye bye.